What I'm going to do is really address the issue of how we look for the evidence of community participation on improved health outcomes. And I'll explain its importance and my findings. I've just finished a paper on this and now doing the final editing for publication in Health Policy and Planning while I'm here. But I want to share with you my findings. So first of all, let me give you a bit of a background to this subject. If you think about it, community participation is not new. It has people, ever since they've been in communities, have proved and supported each other, have given them health, have proved community supports. And so if you think about it, we probably all have been in some way a carer or provider of care to people we know. A more formal approach to this subject or topic was really, in the 20th century, could be traced back to the Rockefeller Foundation, who gave money to a project in China called Dingxian in the 1920s. And it was here that you could trace the origin of the barefoot doctor, a term perhaps you're familiar with through the history. Really, a barefoot doctor was a community person who was trained in basic health care, who could provide basically first aid services and referrals to poor rural communities, but it was also an agent of change to help communities change their attitudes and behaviors. And this, as I will say, became more popularized in WHO in the 1970s. And it was here in the 1978 Alma Ata Declaration, which was the declaration signed by, at that time, 120 of the WHO countries. There's more have been added since, that proposed and accepted primary health care as the way health policy in all their countries would be put forward. And community participation was a key element of that declaration. But let me give you a bit of a background of where community participation is. The field in health, curiously enough, and not surprisingly, when it looks at community participation, sees it in a biomedical paradigm. And this paradigm values the outputs over income. It looks at indicators for measurable indicators over process, and thus the quantitative measures become much more important than the qualitative. And for health planners and managers who have to implement programs with community participation, they look for tools that measure these outcomes, but may, and usually my argument is, don't tell how and why they worked. So as a result of this view of participation, social scientists have struggled to add value to that whole dialogue. And one of the results is when I first got into the field, which was about 40 years ago, that social scientists were marginalized and very rarely listened to in by health planners and ministries of health. And it wasn't until the HIV/AIDS epidemic where the doctors no longer had either the tools to prevent or cure the epidemic that social scientists became in to ask, how can we change people's behavior? What can they add to tell us why people act the way they do? So the financial constraints for healthcare became much more loose with the HIV/AIDS epidemic. And partially out of that, and certainly linked to it, was a further investigation and allocation for funds to look at the social determinants of health. And despite all these challenges, the idea that health is not rooted only as the absence of disease or can be cured by medicine has begun to take growth in many medical and academic institutions. And WHO certainly has promoted this through its own report on the Commission, by the Commission of the Social Determinants of Health, and through the conference in Rio in Brazil, and now again leading up, trying to integrate this idea into universal coverage, which is the new mantra of WHO. So there is, on one hand, a recognition and a growth of what that approach tells us about improving health. But the present day concerns about community participation certainly have shown that in the period that followed 1978, there has been an erratic recognition of the role of communities. When primary health was first started, within the first year or two, several governments had started community health workers as a follow-up on the idea of the barefoot doctors, community people in their communities serving their own people. But those quickly faded, and for about 20 years, community health workers were written off the national government agendas. They would continue, particularly in Africa and Asia, in small NGO, non-government organizations, but certainly not on the national governments. And one of the reasons was that the governments who started these programs realized there was a contradiction between these people who were based and accountable to their local communities and the supervision and eventual role that government would have to play. And there was a concern that the government would be adding new staff to their already full staff programs that they couldn't afford. So government programs went off. But again, interestingly enough, having 40 years of this gives you a whole new perspective. With the crisis in human resources for health, they've gone right back on the agenda again. I'll say a bit more about this, but essentially, particularly because of what happened with HIV/AIDS in Africa, where so many of the health staff got the disease and died. There was depleted the available health carers. And so there was a great hue and cry when WHO in 2006 published their report on the lack of human resources in health, and has since put a lot of money and a lot of publicity and evidence into the result of this crisis. Concerning the role of communities, though, there is not enough evidence on what community participation can do to actually have it as a uptake in community medical and health education. So your own university here does not, I gather from what I hear, take seriously the importance of community participation. And that's true of other universities too, and the medical services that, that are provided. I've lived 40 years out of the States. I went back 3 years ago, and I'm now working in a health system that is an American health system, where the government talks about primary care, not primary health care, and communities are not valued, or they're looked at as a receptacle for professional advice of what to do. There is very small movements of actually asking communities what they need and how they can be involved in decision making. And I would argue, and as I have to colleagues here, one of that is view is the result of the crisis in human health, and that the Americans see health as a commodity, not as a human right. So they're selling things, and communities don't produce a lot of income. In any case, the result is that there isn't enough evidence to put community participation on the educational or program agenda of governments. There are exceptions, and national and NGO programs. And there is not enough evidence to get the financial support you need to keep these programs started and continued. So, let's then go back to explain why this might be such a problem. And I just want to walk you briefly through the underlying concepts of looking at community participation and the challenges it brings to link participation with evidence of health improvements. And I think we could start easily by defining what is a community. And communities are rarely homogeneous. And traditionally in the health field, this doesn't happen in agriculture, I might say, that communities are defined by geographic boundaries. And if any of you can look at this classroom to see that they're not homogeneous, right? But if you've been in a community, you know there are people that group together for different reasons. And I've given some of them, they have a common belief and goal, they have a common culture or value system, they are defined by planners who have certain at-risk health problems, mothers and children, people with diabetes, et cetera, et cetera. There is no common definition of a community, and that makes it certainly a challenge to look at the link between health outcome and that definition. So then we also have to ask about what is participation, and there are three ways of looking at this, and I will elaborate this in a different context in another slide, but this was my PhD, and essentially it still holds fairly strong in the way in which community participation in health is interpreted. The first is the medical approach, which is you people come and I'll tell you what to do and you're participating. Come get your vaccinations, use condoms, yada, 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 but we'll tell, you know, we know what's good for you and we motivate you to do our uptake. The second approach is where communities, and we have lots of evidence of this happening, contribute time, money, labor to activities which are defined by planners. So come and help us build a health center, come and help us dig latrines, come and help us, community health workers sometimes define, come and help us deliver basic health services. But the community is not involved in defining any of those or the actions they imply. And the third is the planning and development and monitoring of and evaluating a program, which could be called a community development approach, and that gets into some of the other terms I'll talk about, empowerment and community choice. So participation can be passive or active. People define participation as numbers who turn up. You guys are all participating in this lecture because you came, right? Those guys aren't, they're not here. Or it can be active where communities actually have decisions or give resources, etc. It can be top-down. People tell you what to do and you respond. Or bottom-up. You tell people what you want and they respond. And it can be seen either as contributive, you give something, consultative, I ask you what you want, or collaborative, where we plan together. But all these definitions are used as for participation. So now I'm going to see if you're awake, because these things all fall out of the sky and I can't stop them. I want to tell you why participation is important. See, there they are, falling out of the sky. Okay, first of all, the arguments are people have much to contribute from their own knowledge and experience to improve health conditions. So a person goes in and tells people, you should do this. But these communities, and my particular example is rural Africa, where people have been surviving for centuries without those people telling them what to do. So they must know something. A second important reason is people tend to be committed to seeking solutions to problems when they've been involved in their identification. So people, if they have a stake in it, or if they believe that, the argument goes, they will be able and more interested in doing something rather than being told what to do and not being consulted at all. A third is that certainly participation can increase skills, knowledge of local people, and their confidence, and thus providing opportunities for them to improve their lives. And this empowerment argument has become very strong in the dialogue. I'm not going to spend much time on it because that's not this lecture, but just to prove. Here comes some more falling out of the sky. Pretty good. They just go beep, 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 and then you were real. I stopped that. People's involvement can increase resources, obviously. And the World Bank, says that community participation creates a social learning process where local people learn from professionals and vice versa. And finally, much to the attraction of the Americans among others, and certainly the Social Democrats, it is argued community participation reflects a commitment to social justice and the promotion of democracy. I sort of question this now after what's happened in Egypt, but we won't go there either. Okay, I just want to say, in light of those assumptions, back to those approaches to community participation, the medical approach defines health as the absence of disease, and participation, as we said, doing what the professional says. And this comes into the dialogue now of the whole economic dialogue of cost effectiveness. What are we going to put our money into? So that argument would certainly answer the effectiveness course. We know what's good for you. You do it, you'll get better, or prevent whatever's going to happen to you. The second, which we said was the health services, is really more about resource mobilization. So let's get people to contribute. It reduces our costs as government or as an NGO, and this will improve health. And the final one is the development, the community development, which answers the political critics on social democracy and justice. So, let me come back to my research. That's just a bit of a background for you. My research question is, or was, I'm finished with it now, I think, maybe. What is the evidence to support the contribution of community participation to improved health? The research objective was to seek evidence to link CP and better health outcomes. And the methods were to examine 16 systematic reviews that investigated those questions. So, I am going to now review to you what those reviews revealed to me. I first of all took the community health workers because they were the initial response in WHO in '78 about what participation was. At one time, primary health care was equated with community health workers, so this became a big policy symbol in practice for promoting participation. Of the reviews I looked at, there was strong evidence on the ability of these community health workers to provide a service. And there's been lots of reviews showing you can train them, that they can react, that they will provide the service. There is the recognition that the role of the community is important in terms of decision-making, of empowerment, of being as a change agent, but the reviews have no evidence of that. And so these are reviews done by the Earth Institute at Columbia University, of Johns Hopkins, a review done by the Lancet in their MCH series. All of them say we need community empowerment, we need community ownership. They state the words, they don't state the evidence. They say more research is needed. They don't know how to get that component out. And it's interesting. The countries that seem to have dealt with this on a national government level are both India and Brazil, where they are, both in the India case and the Brazilian case, those community health workers are part of the government establishment. There is some monetary consideration given back to them for their work. In India, it's the number of women they bring for delivery in health services. In Brazil, they join what is called a family health team as one of 4 members, and they are part of interacting and giving information in the health promotion. But in both those cases, there isn't very much evidence of how that works. What you get is the statistics, things have improved, but what role that community health worker, and the Indian case is particularly interesting. I know a bit more about that, mainly because I've worked in India and I've never been to Brazil, so that's been off my list. But the Indian situation varies from state to state, and some states, the state government has said, we're going to take all this money allocated and we're going to give a salary to these ASHAs, they're called. That's the community health worker. In some states, they are only paid for what they bring to the hospital. So this whole idea of empowerment, of decision-making, which is stated as part of their objective, has not really been tackled, and I think it's a hard one. Okay, so those are community health workers. The other group of systematic reviews I found looked for the direct link between community participation and change in health status, and mainly in the areas of disease control. So there was a review on Chagas disease, which is a disease that grows in little bugs that are in huts, mud huts, and mainly in Brazil. And they showed how community participation did improve the reduction of that disease and dealing with it. But they noted that if that program had fostered empowerment, it would improve the health. But there's no evidence. And that it was, as I found, I was talking to Anita early today, a lot of research ends up being advocacy, not research. People put forth an idea they have, but they don't have the evidence. And particularly around community participation, that tends to be a challenge. So this is what this said. Yes, we know we could do better if we empowered people, but so what? How do they know that? Okay. The one that I've taken on head on and published in the Lancet on was the birth outcomes of women's groups in Nepal, where they did 7 studies. They did meta-analysis in Malawi, India, Bangladesh, Nepal, and they defined a key role for women's groups, right? The challenge, there's no question about their evidence, and they did random case controls trials, which I'll talk about. Standard, good, evidence-based medicine. They never described or described in any detail or with any great confidence what a woman's group is. So how do you replicate this? Does that mean if I go out and get a bunch of women in Varna and put them together, they're going to have better birth outcomes? What is that process that happens, right? So I told the Lancet that, and the authors always get responses to this. They say, we agree with Rifkin, but, and then they went off and answered a totally different question, which is exactly what they do when they don't agree with you, in case you haven't noticed. Something that academics learn pretty well. So, another study I found was from Australia, from the rural health improvements. They found the community participation did improve rural health, but there was no direct evidence of the link between that participation and the health outcomes. They had a lot of studies they could see where there was evidence health had improved, but not from the direct intervention. And that's in all of these cases, and I'll explain as I go on in the discussion, the community participation was looked at as an intervention, not as a process. So they couldn't find the link. And WHO, my love, they're nice people there. I read the article. I know one of the women who wrote it did this one on maternal and child care, and they found no evidence about how community participation succeeded or failed in improving health outcomes. They found that there was evidence that they improved where they had community participation, but they could not, if you will, identify the exact link. And they said they needed more qualitative research. I'll take that one up too. Okay. I looked at those who looked at community participation and improved health systems, a big focus for WHO since 1988 in the Bamako initiative. And the study done here where the two authors looked at a massive amount of evidence. I think it was something like 400 articles and then exclusion, etc. What they found from all this, first of all, there was a lack of comprehensive and generalizable approaches to community participation and its relationship to improved health. Secondly, in another study by McCoy, who looked at health committees, which has been another way of integrating community participation into health, and they took a look at this one, they could find where these committees worked where the government and the local leadership supported them, but there was only internal validity, not external validity. You couldn't say that would help work in every case. And when this group in Africa, again, systematic review, Molyneux and her colleagues looked at community accountability, again, they could identify domains that you needed to look at, but you could not use those to improve that the link between participation and improved accountability existed. There were two studies done in the UK, systematic reviews, about what they call community engagement. It's another term for this. Both of them found no evidence that there was a direct link from the studies they had. But the second one did find that community participation did have apparently a direct link between a positive impact and improvement in housing, crime reduction, social capital, and empowerment. So that's an interesting finding. So let's talk about what all this means. First of all, as one of the reviewers of this paper I've been writing said, does this mean community participation has no value at all to what you're doing? The guy didn't read the paper. I said, no. So I wrote a big paragraph about how all these studies had identified that community participation did make a contribution. In health, there was participation and health got better. What they couldn't identify is why or how. They didn't, and understandably, because the people who did these reviews mainly were not social scientists. They were mainly medical doctors or medically trained people who used random case control studies. The intervention is community participation. What is the link? We have a control group and we have an intervention group. What do we know about the control? And then is there improvements? And you can't do that because these studies were developed on several assumptions between the value of community participation to health that were unproven. And finally, as I've said earlier, that the framework used random case control studies, which looks for a linear cause between a cause and effect, and if there's no causal relationship, that effect or the outcome gets defined as a confounding variable and pushed out, where it could be the key to what works. So let me just say some of the assumptions behind participation that so far haven't been proven. First of all, communities want to participation in health improvements. My own research showed, and I've read follow-up research on this since I did that thesis, that communities want participation when they're sick, when there's an epidemic, when they need resources. They don't innately want health. So why should a community people get involved in something that they don't see as an immediate and appropriate interest? So if you're thinking about participation, you have to think, why do people want to do this? What are their motivation? The assumption is they want it. They've never investigated this properly. Secondly, there is the assumption in the politically correct world which we are now living that participation will ensure equity and sustainable distribution of resources, leading to social justice and the right to health. one of the most interesting studies I've read of late is from the World Bank by these two authors, Mansouri and Rao. And at the end of this presentation, I give the references, so if you want to go back and check this, in which they show the studies that they did in health, and they didn't only do health, they did agriculture, they did education, etc. But in health, what they found is the people who profited from being involved in community participation in healthcare were the people who were already getting the services, who already had access to resources, and they did better. So the ones down here who were to be the intended target were not profiting from these. And the bank, I mean, they did this study, because they had they've had over $1 billion in participation, not only in health, but in all areas. They wanted to, the study was it worth the investment? What have we gotten? What have we learned from the money we've put in? And this was just one of the outcomes in the health thing. There's also an assumption participation will create capacity building and empowerment. But in fact, it doesn't by itself. It needs the right conditions, it needs the commitment of governments, it needs the commitment of leadership, all these other factors that allow that to happen. Not that it hasn't happened, but by itself creating a health committee doesn't provide better health. And community participation generates a sense of ownership to the health intervention. Not necessarily, as they're not interested, they don't care whether they own it or not. And so often the people go into communities and say, what you need is, and the community says to you, listen, you've defined the problem. That's not our problem. You solve it. You give us the money. You put in the infrastructure. You provide it. We've got other problems. And finally, that community participation will promote democratic approaches to governance. Well, I've already mentioned the Egyptian situation. I won't go any further. Okay, so then what is the challenge? We don't have problems nowadays. We only have challenges. What is the challenge of using a random case control study? And Simpson and Fisher and his colleagues have pointed this out in an article which I think is worth reading. First of all, if you're looking for evaluation, what are these studies, what are their evaluation when you're looking at any population health intervention, not only participation, but any intervention you want to make for improved population health, not individual health. And these include, is the population available? What is the time to follow up that intervention? Think about now community participation as an intervention. This is how they're looking at it. What's the external validity of that intervention? What about contamination? One community, your control community, sees what's happened and adapts it, whether you like it or not. What about the cost of doing this? What about the ethics and informed consent? And what about the inhibition of new research questions? So all these make that particular style of, or particular framework to evaluate participation in terms of health outcomes not very reliable or replicable. So the specific challenges in community participation are, as we've said, what is a community and what is participation? We have no standard definitions. So if it's women group in one place, it could be community health committees in another. How do you look at an intervention that is generalizable if you can't define in detail that intervention? So I'll just give you some examples about this. I've picked two. One is Uganda, where these nice economists, who apparently are really good at numbers and made these big equations that I didn't understand. I did understand the outcome. Their results indicated, of the 9 districts in Uganda, the result indicated increased utilization and reduction in child mortality and increased birth weight. So they did the figures, they did a community monitoring, they went back in 9 months to see if there had been any change, and they said, yes, there had. But the question remains, first of all, why would the health staff respond to community monitoring. The community neither has the money, it doesn't have the power to tell them what to do. What happened in that interaction that made those staff respond? They haven't, ever since the health service has been initiated. One of the big problems is getting local people to do what we know scientifically is good for them. They don't do it. What happened in this case? I'll come back to the question of power. And secondly, was the intervention sustainable? Did they continue to do this when they didn't get money and paid from the outside? And did it increase community capacity? Did it increase ownership? None of these critical questions about the role of participation were answered. The second example is these random case control studies of women's groups. And they published this as to their mistake, which is why I took them up, was as they were trained in what is called participatory learning and action, PLA, which really means communities define, people in those communities define their role and they're involved in decision making, and the whole view is to have people change their views and learn new skills, capacity, and confidence to continue the behaviors that they developed during this intervention. Well, as Cesar Vectora, who has written for years on MCH and picked this up also in the Journal of Epidemiology, said, the thing is, he's very nice because he's been trained in Britain and he knows how to be polite, right? So he didn't really say what he meant. He said it's a really good study, and John Snow started out looking at the cause of cholera, and it took him a long time to prove it, and this is a start to prove this thing, and it will take some long time, and I don't want to discourage you from continuing. But the reality is that the reason you use PLA is to raise women's ability to improve their impoverished lives, not to get better health outcomes. The whole process is about helping people to get some control over their lives. So it's very difficult to say what that relationship is. So you have to ask, did the women continue to practice to what they learned? Did they have some ownership of that program and what they had learned? Did they stay together? Did they continue to support one another? And were the outcomes sustainable over time? Did the next birth outcome put them back? Did they use women's groups again? Did they find a women's group? How did they proceed from what they had learned? So, the conclusion of all this investigations were the RTC framework reduces investigations to a simplified explanation for a complex and highly nuanced interaction between professionals and community lay people and the intended beneficiaries. And secondly, it's more valid to look at community participation as a process which can be defined usually fixed or ordered series of action or events leading to a result rather than a static, repetitive event. So there are people who have worked on this. I'm not the only one who figured this out, unfortunately. Anyway, I'd be really rich, huh? So Pawson is one of these people, and this is his take on it. He says you have to look at the theoretical framework you're using and then look at the empirical evidence to test the framework in support or contradiction for modification, and then combine the theoretical and empirical evidence to focus on the content, which is the intervention is implied, and to work it out. So in other words, we need to have flexibility given what our goals are, and to adjust that so we can look for what we really want, what we're looking for. And looking at participation as a process then allows you to look at it as a change over time, which can start with mobilization and move toward empowerment. So another thing I've worked on is a way of doing this, which is the presentation of an evaluation framework called the spidergram, which defined from 200 case studies from WHO 5 domains which were critical to whether participation was successful or not, which included who did the needs assessment, was it the professionals or the community? What was the leadership in the community like? Did they care for only their own group of people, or did they have wider concerns about those who were more marginalized and poor? How was the program organized? Was it integrated in existing programs that already had frameworks for promotion, or did they start it out as another program added on other things communities have to do? How were the resources mobilized? Did the community contribute anything, or was it all funded by outside donors? And management, who was responsible? Were people outside the community, professionals running it, or did community people have that role? And then you plot those along that continuum. If you're wide, you're at 5. If the community does lots, if you're narrow, you're at 1, and you plot that beyond that. And here is a framework on which chooses, please. No, that's no problem. And this is the framework by which you can choose where to make that indicator. And again, you can have the PowerPoint. I'm not going through this, but there is a framework, a matrix, so you can decide whether it's 1 or 5. And here's just an example of it in Cuba, and that's all in Spanish, but you can see they took each of those things, and the light line is where they were when they started, and the dark line is how it changed over time. So people have used this, and I've got a list of programs that have used this particular framework to see the changes. And sometimes, you know, it reduces, it gets smaller, it doesn't always get wider, but it allows a program manager to see where there is a concern and why that has taken place, so they can be able to, you know, make the adjustments they need to do. So what does it tell us? It tells us about what are changes in participation over time. It tells us participation as a process. It's a method of looking at participation as a response to social, historical, and cultural factors, and key factors that influence how participation develops. But this is only the beginning of the investigation. These 5 factors are not written in stone. They need to be more clearly defined, and they need more other factors that can influence participation also need to be defined. More studies need to be undertaken to seek and identify influences of these factors and to see how these factors can be more generalizable. And we really need, and I've said this again and again in what I've written and when I talk, we really need an understanding to see the role of power and control in participation, because it is a political process, and it is that tension that challenges its success or failure. So this is the end of my lecture. These are my take-home messages. This is what I want you to remember. I want you to remember to date that CP, health intervention, has mostly been examined in health as an intervention. That to gain more understanding of its importance and to ensure its validity, it must be seen as a process, and we need to have more robust frameworks that link CP and improved health outcomes. So thank you very much.